Welcome to this series of videos on communicating with chronic pain patients. This is Module 6, Hope, Expectations, and the Power of Our Words. Imagine two patients receive exactly the same MRI result. The first patient is told, "You have significant degeneration in your spine. Your discs are worn down, and you have several bulging discs." The second patient is told, "Your MRI shows some age-related changes that we commonly see." The encouraging news is that these findings don't necessarily prevent you from becoming stronger and more active. Same MRI, same patient condition, but potentially two very different messages. The first message says, your back is damaged. The second says, there are changes in your back, but there's still reason to be hopeful. And that difference matters. Because when we're communicating with patients experiencing chronic pain, our words don't simply communicate information. Our words can also shape expectations. We sometimes treat expectations as if they're irrelevant to clinical outcomes. If the treatment works, it works. If it doesn't, it doesn't. But pain doesn't operate quite that simply. Pain is influenced by many factors, including previous experiences, beliefs, context, fear, and expectations. Research on placebo and nocebo effects demonstrates that expectations can influence the experience of symptoms, particularly pain. A placebo effect occurs when positive expectations or contextual factors contribute to an improvement in symptoms. A nocebo effect essentially moves in the opposite direction. Negative expectations can contribute to worse symptom experiences, and this creates an important responsibility for healthcare providers. Because we help create expectations, think about some of the language patients here in healthcare. Your knee is bone on bone. Your spine is degenerating. You have the back of an 80-year-old. Your disc is blown out. You have terrible posture. Your core isn't supporting your spine. Whatever you do, don't bend over. The provider may simply be trying to explain a diagnosis. But what does the patient hear? I'm damaged. My body is fragile. Movement is dangerous. I need to protect myself. And those beliefs can influence behavior. If I believe bending is damaging my spine, what am I going to do? Avoid bending. If I believe pain means I'm causing additional damage, what happens when exercise hurts? I stop exercising. If I believe my spine is progressively deteriorating, what happens to my expectations for recovery? They may decrease. Our language can unintentionally increase the very fear and avoidance we're trying to reduce. Now, there's an important distinction. Creating positive expectations does not mean lying to patients. It doesn't mean telling every patient, don't worry, you're going to be completely pain-free. That's not appropriate either. Hope is not the same thing as a guarantee. Instead, our goal should be accurate information delivered in a way that doesn't unnecessarily increase threat. For example, instead of, your spine is degenerating, we might say, your imaging shows some changes that become increasingly common as we get older. Instead of, your knee is bone on bone, we might say, there are arthritic changes in the knee, but that doesn't tell us everything about what you'll be capable of doing. Instead of, your back is unstable because your core is weak, we might say, one thing we can work on is gradually increasing your strength and confidence with movement. We're not hiding information. We're framing accurate information in a way that promotes possibility rather than helplessness. One of the most useful concepts we can communicate to chronic pain patients is that pain and tissue damage are not always the same thing. That's not the same as saying, your pain is in your head, and we have to be extremely careful here. Remember what we discussed in Module 3. Validate first, educate second. Imagine a patient says, my back hurts every time I bend, so I know I'm damaging it. Don't immediately respond, pain doesn't mean damage. Start with, I understand why you'd think that. If something hurts every time you do it, it makes sense to assume something is being harmed. Then you might add, one thing we've learned about persistent pain is that the relationship between pain and tissue damage isn't always as straightforward as it is with a new injury. Now we're providing information without dismissing the patient's experience. There's an entire area of chronic pain treatment called pain neuroscience education. The goal isn't simply to teach patients anatomy, it's to help patients develop a less threatening understanding of what pain represents. A systematic review and meta-analysis of adults with chronic musculoskeletal pain describe pain neuroscience education as an approach intended to help people reconceptualize their pain as less threatening. More recent research continues to examine this approach. A 2026 systematic review and meta-analysis found that pain neuroscience education can improve pain and several psychosocial factors in chronic musculoskeletal pain. Other research has found benefits for things like fear of movement, sometimes called kinesiophobia. But there's an important lesson here. Education shouldn't become another lecture. Simply explaining pain neuroscience at someone isn't enough. The way we communicate the information matters. So how do we communicate hope without making promises? One strategy is to shift the conversation from certainty about outcomes to possibility of progress. Instead of, I know this treatment will get rid of your pain. Try, I can't promise exactly how your symptoms will respond, but there are things we can work on that may help you become more active and confident. Instead of, you'll be back to normal in 6 weeks. Try, our goal is to gradually increase what you're able to do, and we'll adjust the plan based on how you respond. Instead of, there's nothing wrong with your back. Try, I believe your pain is real, and I'm also encouraged that pain doesn't necessarily mean your back is being damaged every time you move. Notice the combination, validation plus hope. We're acknowledging what the patient is experiencing while communicating that their current situation doesn't necessarily determine their future. We also need to be careful with metaphors. Healthcare providers love metaphors because they make complicated concepts easier to understand. But metaphors can also create powerful mental images. Imagine telling someone, your discs are like worn-out shock absorbers. What picture does that create? Something broken that needs replacing. Or, your knee has no cushion left. Again, something has disappeared, and now the bones are grinding together. Once that image is in the patient's mind, it can be difficult to remove. Before using a metaphor, ask yourself, what picture will this create in my patient's mind? And more importantly, will that picture make them feel more capable or more fragile? Here's something you can start doing tomorrow. Before explaining an imaging result, diagnosis, or prognosis to someone with chronic pain, ask yourself 3 questions. Is it accurate? Am I communicating what we actually know rather than overstating certainty? Is it necessary? Does the patient need this information in order to make an informed decision or understand their condition? And how might the patient interpret it? Because what we say and what the patient hears aren't always the same thing. Our words are part of the clinical environment. They can increase fear or reduce it. They can create helplessness or possibility. They can make a patient think, my body's broken, or my body may be more capable than I thought. That doesn't mean giving false hope. It doesn't mean minimizing pathology. And it certainly doesn't mean telling patients their pain isn't real. It means combining honesty with thoughtful communication. So choose your words carefully. Be accurate. Validate the patient's experience. Avoid unnecessarily threatening language. And when the evidence allows it, give patients a reason to believe that progress is possible. Because when we're treating chronic pain, we're not only influencing what patients understand about their bodies, we're influencing what they expect from them.